Brittany Weber, yeah, she's director of cardio-rheumatology at UT Southwestern, recently moved from Harvard. She's a cardiologist by training, did an immunology PhD, and is absolutely passionate about cardio-rheumatology, and is going to just give our guest lecture to round up this fantastic day from a clinical and a research cardiology perspective in terms of state of play of cardio-rheumatology.
Good morning or good afternoon, everyone. It is my pleasure to be able to talk to you today virtually on my near and dear passion of cardio-rheumatology. I've probably met many people in the room today, had the opportunity to work with Dr. Young, Dr. Books and Dr. Youngstein over the last number of years. And today I'm going to be talking to you a little bit about what we've been doing over at my own institution on cardio-rheumatology, titled Cardiovascular Prevention in the Face of Systemic Inflammatory Diseases. So my name is Brittany Weber. I currently am the director of a cardio-rheumatology and dermatology, which adds in psoriasis and other diseases that have enhanced risk at the University of Texas Southwestern Medical Center. I've recently transitioned from the Brigham and Women's Hospital, where I did my training, I started my faculty, and I started the clinical cardio-rheumatology program there. And so you will see a lot of research today that I've done at the Brigham, because I literally just transitioned a few weeks ago. So with that, I will get started. So here are my disclosures, including my grant funding. And so to begin, we have known since the 1900s of the role of inflammation and atherosclerosis. Indeed, this was first described in the 1858 on the pathological findings by Virchow, who first described the inflammatory infiltrate of the artery. And we can fast forward to the 1900s and 2000s and see how rapidly advancing our field has becoming. And so it's complex, and we can now appreciate the fundamental role of both innate and adaptive immunity. So in the 1900s, we first knew about endothelial activation, leukocyte adhesion molecules, and fast forward, we began to have mechanistic studies where we appreciated both the role of the innate and then the adaptive immune responses. And this has been corroborated by both clinical and epidemiological data from observational studies, as well as down to randomized controlled clinical trials. And as a cardiologist that's been interested in immunology since I was a teenager when I started studying the immune system, it's an exciting time because everything has changed. This is really the first proof of principle concept study that many people in the audience today may know about. This is the CANTO study, which demonstrated for the first time that a pure anti-inflammatory therapy, canakinumab, so an IL-1 beta monoclonal antibody, led to a reduction in major adverse cardiovascular events among patients with cardiovascular disease. We've also had increasing data on the role of colchicine in cardiovascular disease risk reduction. This is one of the landmarks, the LODOCO-2 trial, that demonstrated a dramatic risk reduction in colchicine compared to placebo among patients with stable coronary disease. And I will say, as a cardio-rheumatologist, this was an exciting time in 2023 because the FDA in the United States, for the very first time, they approved anti-inflammatory therapy, pure anti-inflammatory, for reducing cardiovascular events with colchicine. Now, the colchicine story is we're still learning where colchicine may be more beneficial and less beneficial in terms of different disease contexts of the cardiovascular system. However, we now have an established therapy in our guidelines we can be utilizing in our patients with high inflammatory risk. And so that really brings me to the next slide, is that we are now testing in the cardiovascular patient anti-inflammatory therapies for cardiovascular risk reduction. We have learned a lot from our own rheumatologic diseases where I live and breathe, the central role of the NLRP inflammasome that will ultimately activate cytokines and activate the downstream, one of the key drivers of IL-6 that will produce the acute phase reactant high sensitivity C-reactive protein. And what this slide is showing you is just the multiple therapies that have been tested or are being tested in the United States for cardiovascular risk reduction. So if we start up high, we know that the NLRP3 inflammasome, there are multiple phase 1 and phase 2 studies that are ongoing of blocking this pathway. I've already mentioned colchicine, and this is starred because it is both a phase 3 cardiovascular outcome trial as well as bolded because it's the FDA approved agent in the United States. There is a phase 2 bispecific IL-18 and IL-1 study. canakinumab is the IL-1 inhibitor that has been tested, as I just showed you on the last slide, in a phase 3 cardiovascular outcome trials. Everyone on this call listening in will recognize other names here, such as anakinra and other IL-1 blockers that we utilize for other conditions of cardiovascular disease, such as pericarditis. And then we have multiple different agents that block IL-6. And both clazakizumab and ziltivekimab are two molecules that are now being tested in phase 3 cardiovascular outcome trials in the United States across a range of cardiovascular conditions. Include ziltivekimab is being 3 different trials are testing the hypothesis of whether inhibiting IL-6 in both heart failure with preserved ejection fraction after the acute MI or stable coronary disease among patients with CKD will lead to a cardiovascular risk reduction. And so, as that primer, I think we could all agree that immunology really sits at the pillars of all forms of medicine. No matter what type of doctor you are in the audience, there really is an integral role of the immune system. And what I just kind of told you about is the exciting times of cardio-immunology on the leftward axis here. But what we're all talking about today and where I sit and breathe and my passion is as a cardio-rheumatologist. Rheumatology being the field of medicine that's taking care of patients with immune-mediated inflammatory diseases, and the burgeoning field of cardio-rheumatology, which is the specialists that are uniquely dealing with these types of patients and conditions. And so, epidemiology and significance. I probably don't have to convince all of you, but it's not that uncommon. Approximately 5 to 8% of the general population are affected by an autoimmune disease, and we know that autoimmunity disproportionately impacts women. We also know that there's a really important intersection of chronic inflammation with traditional cardiovascular risk factors. We know that immune-mediated inflammatory diseases are not adequately estimated by risk by our standard United States cardiovascular risk calculators. Similar would hold true by the UK. And so in the ACC-AHA pooled cohort equation guidelines we will utilize for risk assessment in the US, we now have recognized that these are risk enhancers, at least saying the notion that we know that our risk tools are not adequately or predicting. What we also know from epidemiological study, though, is that our traditional risk factors, so the things we can treat, hypertension, obesity, they are both hyperlipidemia. They're not only more underdiagnosed, they're often undertreated. So we have to treat the risk factors that we can treat among our patients with immune inflammatory diseases. And so when we think about the scope of the problem, I really like to show this slide to show you how diverse it is. And you're probably discussing a lot in the conference today, as well as you may be thinking about all these different manifestations by which our patients can present to us. I like to put it into these broad buckets. So we have the vasculature. We all talk about and we think about accelerated atherosclerosis. I've also worked a lot on coronary microvascular dysfunction, which is prevalent in these conditions, important endpoint. There's a host of other number of vascular phenomena listed here, including vasculitis. We've got pericardial disease. Our patients can frequently present with pericarditis, and treating these patients can be sometimes very nuanced and challenging. We've got valvular disease. We've got certain involvement with certain disease entities such as Liebman-Sachs. Myocardial, both myocarditis, very important, as well as heart failure. Patients who are on long-standing antimalarials, you have a rare but very important side effect of hydroxychloroquine-induced cardiomyopathy, as well as electrical complications. So you can see here just how diverse the way our patients can present to us and the need for us to understand mechanistically this and help to kind of really drive forward that prevention in our field. And I really like this quote that was published over a decade ago by one of my dear mentors, Dr. Libby, as well as the late Justin Mason, where they wrote in a review article where they said, systemic inflammatory rheumatic diseases associate with an increased risk of atherosclerotic events and premature cardiovascular disease. However, the precise nature of the relationship between local and systemic inflammation, their interactions with traditional cardiovascular risk factors, and their role in accelerating atherogenesis remains, keyword, unresolved. And I would argue to all of you listening today that this is still unresolved. We've made progress, but we have a lot of work to do in the field. And that's why it's also an exciting time and really exciting time for myself to see everything that the UK Cardio-IMID partnership is doing. And so what are key questions for the future? So How, when, and what to screen to identify CV risk among patients with IMIDs or ongoing systemic inflammation. How do advancements in the targeted therapies of inflammation, so the vast array of biologics, and our advancements in imaging, how does that translate to a clinically useful tool we can all be utilizing for diagnosis and monitoring in our clinical practice? We're talking about a special population today, people with immune-mediated inflammatory disorders. So when you're thinking about a special populations, how do we think about imaging playing a role in the collaborative care model among all the different specialties? Answers this partnership is going to be addressing and answering, and I'm, again, very excited about. And then more broadly, how does disease detection evolve from the IMID population to the general population at large who present to us with positive inflammatory markers? So again, be thinking of these big picture questions in your head. And we're going to talk a little bit about some of the tools that we've currently got in active research efforts, but these are kind of the questions I would charge all of us that we still have to address in the field. And so one exciting thing for myself is that I certainly feel like a kid in a candy store as a cardiologist because we have the expansion of cardiovascular imaging tools. As you all very well know, as part of the UK CARDIO-IMID partnership, we can oralize advanced imaging. So there still is a role for echocardiography as well as exercise ETT, but we're beyond that. So those will still have roles in my assessment, but now I can order much more sophisticated tests when I'm working up a certain symptom or potential etiology, such as if I'm worried about coronary microvascular dysfunction, I frequently use perfusion PET, shown here on the bottom left. You can see here the gorgeous view of the vasculature of the heart, like how abundant that is. We can do coronary CT with very advanced technology that's emerging and quantitative plaque imaging. We've got photon counting CT. We also have novel metrics of being able to detect coronary inflammation, work that's been being spearheaded at Oxford. This is a picture of what the fat attenuation index would look like on the right. Another term for this is called the PCAT, the paracorneal attenuation tissue index. And on the right is a stress cardiac MRI, which I frequently use in my practice and is a very important tool for our patients. This is one of my patients here that also had active inflammation of her pericardium. This is a lupus pericarditis patient. And we can also add flow onto cardiac MRI as well to look at tissue perfusion and the microvasculature. And so with all that as a primer, we have to remember that we need better risk prediction. This was an important study that I really like because the Danish registries are able to look at large numbers of patients that have been followed over time within their healthcare system. So this looked at 85,000 patients and they identified 4,000 patients that had one of 18 different autoimmune disorders. So these are a host of autoimmune conditions, not more than just the ones we are often thinking about and talking about as cardio-rheumatologists. But what they identified in this study was a couple important points. One, if you had an autoimmune disease, you were just more likely to have atherosclerosis. Furthermore, if you had an autoimmune disease and you were to match them to age, gender, and risk factor match patients, you were more likely to have excess cardiovascular events, shown here on the right. And so you can see here the elevated odd ratios for having any plaque as well as having severe plaque. And another important point of this paper that I liked is that they also demonstrated that the risk profile was lower among the patients with treated cardiovascular risk factors. Again, we all have to be treating what we can treat among our patients with our cardiometabolic risk factors. We also know that there's increased cardiovascular risk within our patients that begin in the young. So I would challenge all of us that this is really missed opportunities for prevention. And this is just one study on the left that I had the opportunity to do with one of my mentors in the labs that I've been in, is Dr. Ron Blankstein, where we examined this question within autoimmune patients with a young MI registry. This is a retrospective registry that Dr. Blankstein and colleagues built between our institutions, between MGH and Brigham, that examined patients with type 1 MI under the age of 40. So we looked at this cohort to ask the question, how common were patients with systemic inflammatory diseases? I focused on 3 common diseases: rheumatoid arthritis, lupus, and psoriatic disease. And did these patients have worse outcomes compared to the young patients without systemic inflammatory diseases? And this is the main figure that highlights the finding, was that patients with the IMIDs had an increased all-cause mortality when compared to the entire cohort, as well as a subset of age and cardiovascular risk factor adjusted patients. Furthermore, the study on the right is one I really like because it shows you that the severity in a disease like psoriasis, so the skin inflammation, so what you observe when you see this patient, it matters. This again shows it's an important study done by Dr. Gelfand in JAMA almost 20 years ago now, that looked at the patients with psoriasis who had the relative risk of having a heart attack. And what you can see here is, particularly among the young, the relative risk of having an event among a patient who's walking into your office with severe skin inflammation compared to mild, really showing us that we have to go beyond the biology here and actually think about severity of the diseases of which we're taking care of and how that impacts cardiovascular future risk. And so if you remember my first slide earlier where I said we know that our current risk calculators don't adequately estimate risk. So one thing we do need in the field is we need disease-specific cardiovascular risk prediction tools. This is just one example. There have been multiple studies done across the United States, the UK, and other European countries. This is one I had the opportunity to do with at our own institution with my lupus lab, Dr. Constanbader, and Dr. Choi, who's now back up in Canada, a brilliant rheumatologist, where we did this study. And what we did is we took the patients at our own institution with lupus and adjudicated outcomes, and we try to build upon the standard ACC-AHA risk score and say, can we better identify patients in our institution who go on to have outcomes by adding on lupus-specific risk factors to our model? And so this is just a central illustration. This was published last year, shown here with a reference. But what we determined in our model was that these are the things that came out: disease duration, disease activity, anti-double-stranded DNA, lupus anticoagulant, Rho, low complement, and kidney function. And in this cohort, we were able to identify 3-fold more lupus patients as a moderate to high risk. And not surprisingly, because our current risk calculators always underestimate the young, because these are predominantly age dependent, it was much better at predicting risk in our lupus patients with the younger females. Again, one example. This does need to be validated in larger cohorts, but it's just an example of where we need to be thinking of as a field and how we can be building better disease-specific assessments. So how can we move the needle forward? So one of my big passions and area of my research has been on the role of multimodality imaging. So something I think all of you can also speak to here as part of this cardio-IMID partnership is that I truly believe that integrating multimodality imaging can improve the screening, the detection, and the serial monitoring of cardiac function. I had the opportunity to lead a scientific statement in JACC in the United States with Dr. Mukherjee, where we really try to go through how we can utilize imaging within our patients with these diseases and how different imaging tools can help us address different questions. However, a challenge: we do not have guidelines. So the lack of guidelines leads to variable assessment of CV risk in this population. And so I would challenge as well that by integrating imaging, we can improve cardiovascular outcomes. This is just two case examples. I had the opportunity with the brilliant Dr. Youngstein, that you all know, to work on the next reiteration of the Braunwald chapter that's now in press. And this was a patient on the right here, where I'm showing you the coronary CT, which is a young female presenting with acute chest pain, and that revealed coronary arteritis. Again, multiple examples from the UK I could show here to highlight. On the left, another example where this is a patient at my own institution that I took care of for years with ongoing pericarditis and lupus, and she had failed all the lupus-specific therapies, IVIG, azathioprine. We went down the list, and she ultimately responded to an IL-1 blocker, not a conventional therapy for this disease. And this just shows you how we utilize both her symptoms, her history, and imaging to actually demonstrate the resolution of pericardial inflammation. So again, showing how we can integrate our imaging tools to improve improve our outcomes within our patients. There's a lot of different emerging imaging techniques. This is just a review I had the opportunity to do with Dr. Maverick Jennings, who is a partnership also with one of my European colleagues, where we just show some of the emerging techniques to look for atherosclerosis among our patients with IMIDs. This is not exhaustive, but you can see a lot of the tools that you've already heard me say. We've got perfusion PET for microvascular assessment. We've got MRI with really exciting new tracers with MRI. We've also got PET, which of course I love PET, and we've got novel tracers for PET such as dotatate that's upregulated on macrophages. That really a lot of really cool work we can be doing there. And then we've also got the coronary CT metrics that I mentioned, PCAT, and then the radiotranscriptomic model built on that is the fat attenuation index. So again, lots of tools in our toolbox that we can be thinking about for scientific research and to test moving ahead, but still a ways to go before a lot of these advanced tools are moving into clinical practice. So if you remember back on my expansion of imaging tools, I had mentioned to you the coronary microvascular dysfunction. And so when we talk about how we can utilize imaging in our toolbox, well, one of the things is that we should be thinking about in our patients that are presenting to us with chest pain, shortness of breath, is when we're evaluating the vasculature, is also thinking about microvascular dysfunction. A number of studies, including at our own institution, as well as others, including in the UK, many laboratories there have done beautiful work, including Dr. Book's, have looked at coronary microvascular dysfunction. And one common theme I want you to all remember is that it's prevalent. It's both prevalent if you look at individual diseases, vasculitis, lupus, RA, psoriasis, sclerosis. So it's prevalent. So it's more prevalent when you compare it to age risk factor match controls. It's also prognostic. That was one study we had done in the laboratory when I first started my postdoc, as well as Dr. Fair from Yale, where we looked at, is it equally prognostic among our patients that are presenting with IMIDs? And the answer is yes. So it's an important correlate of risk, because we also cannot do those Paul Richter 10,000 patient trials. So we can also utilize markers of risk when we're asking therapeutic interventions. And with that example, I want to show you one study that I had the opportunity to do with one of my colleagues and mentors, Dr. Liao, who's a rheumatoid arthritis expert at the Brigham and Women's Hospital, where we actually said, if coronary microvascular dysfunction is prevalent and prognostic in rheumatoid arthritis, does giving an RA patient with moderate to severe disease and anti-inflammatory therapy, TNF, does that improve a marker of vascular health using perfusion in PET as our endpoint? And I'm showing you here many years of works down to a central figure. But what we observed was over this study where we treated our RA patients with the TNF inhibitor for 24 weeks or 6 months, is that we observed a few things. We observed one, baseline, low cardiovascular risk patients, they had very high prevalence of coronary microvascular dysfunction. So almost 50% of people had CMD. So again, not something you would ever get on a risk calculator. We saw improvement in the inflammatory markers, improvement of RA disease activity. We did not see improvements in coronary myocardial blood flow, although could it be not long enough, or is the answer a pure anti-inflammatory therapy wouldn't approve? That still needs further studies. We also observed some interesting correlations, such as we saw a correlation between reducing IL-1 beta with the reduction in high-sensitivity cardiac troponin, a marker of risk. So again, more things to still learn from this study, and we are doing more longitudinal follow-up of these patients, but just shows you how we can utilize imaging to address mechanistic questions. I love rheumatoid arthritis. It's one of the main diseases that I study, that I feel very passionate about in the field. And as a cardiologist, I try to teach my other cardiology colleagues that there's important things we can learn from a disease model like by RA. And that is because of the appreciation of the shared inflammatory pathways. And so this is, as people who have done these figures know how tough these could be. This is a lot of labor of love into this central illustration where Dr. Liao and I really try to take it down from all the immune pathways you see on those huge figures. And we take the RA, the synovial joint, we take the atherosclerotic process, and we say, where's the convergence? So let's not show every molecule, but where's the convergence? And what we argue in here is we see this kind of convergence along this pathway you saw early on in my talk, the IL-1 to IL-6 pathway. And I always say, all of you that are rheumatologists in the audience, you guys have been doing this, or you're far ahead of us. You've been treating with these blockers for decades. These are all the RA FDA approved agents that we can utilize in our patients in the US, all the way from upstream with methotrexate, all the way down to the IL-6, TNF, and the newer kids on the block. Well, not really newer, but the agents we're using more commonly now, the JAK inhibitors. And you can see on the right here, we've got the proof of principle concept study, but we are now testing ziltivekimab, shown below. So moving into another point, I'm trying to highlight themes of how we could be thinking about integrated imaging, is we need innovative solutions for identifying risk. So we know that artificial intelligence is really becoming rapidly advanced within not only medicine, but just our day-to-day practice. And there's many different ways we can incorporate AI. One way, when we're looking at coronary atherosclerotic burden, is there's been multiple algorithms that can detect CAC by AI methods from non-contrast chest CTs. And so when we think about all of our patients that you may see in the hospital or in clinic, such as say it for happens a lupus patient comes and gets a chest CT for a pneumonia, that's data that exists in the record. So one question we wanted to ask at my lab at the Brigham was, can we take data that just exists in the medical record, and such as chest CTs ordered for non-cardiac indications among patients that we don't know they have coronary disease, can we identify atherosclerosis and what's the prevalence and prognostic significance? And this was a study that took us many years, that's in press, so should be out soon. I've been very excited about, where we looked at our own data set. So we have 2,500 individuals with lupus, RA, and psoriatic disease. We were able to identify people without coronary disease, and then had chest CTs, analyze them by one of the CAC-AA methods. With this study, we used NanoX, which is an FDA-approved method to detect coronary calcium. And what we observed here was that the patients had CAC, so up to 50% of patients had evidence of atherosclerosis. Again, data that's just existing, very low rates of statin use in this cohort, which we did look at. And then we looked at the prognostic significance. And the point I wanted to make here is that even low levels of coronary calcium, so 1 to 99, very mild, those had a hazard ratio of outcomes that was predicting secondary risk. So the point I'm trying to make to you is that these patients are inherently higher risk. So even detecting mild disease is quite important when we're thinking about getting them on prevention-based therapies. What about other ways we can have innovative solutions to identifying risk? Well, this is a study that we've done at the Brigham, that I also got to work with. He may be in the audience today, Dr. Christos Kananidis. He's a brilliant postdoctoral fellow that had the opportunity to come to the US last year and worked in our laboratory on cardio-rheumatology research. And his laboratory back at Oxford, where Dr. Antonitis has really pioneered the technology of the fat attenuation index. Briefly, in the sake of time, I will just say that this is a metric that takes the concept that when the adipocytes lining the coronary endothelium see inflammation, they can swell. And through radiotranscriptomics approaches, there's been that's the PCAT that then has been built into a model called the fat attenuation index. It's already been demonstrated to be prognostic within the general population. That was an orphan study that people may know what that term means. That was published in Lancet a little over a year ago. But we addressed what is the role of Phi among our patients with those 3 diseases that I just mentioned. And this is just the findings of the study that's currently under review. But basically, the meat of what I want to tell you is that coronary inflammation burden, as measured by Phi, so the highest quartile, it was associated with adverse cardiovascular outcomes among our patient population shown here, which was about 909 patients. And it also still held true in subgroups, as well as patients treated with biologics. So more to come, but just a little bit of studies that we've been doing to address these questions. Lastly, my last point I want to make is that I truly believe we need better precision. So one way we could do that is by immunophenotyping with our advanced imaging. This is one study that I've been working on at the Brigham. These are my immunology collaborators, where we took a hypothesis of whether reducing inflammation by a Th17 blocker would improve vascular health. And we did single cell RNA sequencing of peripheral blood mononuclear cells. And We're still trying to learn the relationship between the immunophenotypes and the vascular health. But what we observed here was pretty interesting. And it's going to be presented at ACR in one of the oral sessions by Dr. Marks, the postdoc who's done this work. And the crux of it is that the people in our trial that responded to the IL-23 blocker, they were the patients at baseline who had pathogenic Th17 cells, whereas the people who didn't get a clinical benefit from the drug in terms of their disease for psoriasis were the people who had more homeostatic Th17 cells. This is a finding that we wouldn't have been able to understand on just like a proteomics level. It really took going down to precision with an immune single cell to actually pull out a finding like this. And that really just leads me into this last example. Was one of my big interests is how can we take advancements with imaging? I showed you these two tools today, take that down to really precise understanding what's going on at the immune cell level to really say what's the relationship between the immunophenotype with our cardiovascular risk biomarkers. And so as I end, I hope you remember these big questions that I started with in the beginning. And this is really where I would challenge all of us on work that the cardio-IMID will be addressing, really have to be answering in the future. And so this is just a central illustration from our cardio-rheumatology working group in the United States of really there's lots of integral relationships between growing cardio-rheumatology, close collaboration between multiple different specialists, imaging, prevention, understanding the different biologics, and ultimately it's going to take many of us all coming together to really fuel this field forward. I'm so excited to see all the efforts that the cardio-IMID group is doing. We are working hard in the United States to also try to fuel these efforts. These are just a few examples. We still have very few clinics as shown here by these few dots on the map. I am now adding a dot down in Texas, which is pretty exciting because there was not one beforehand. We host a yearly conference in New York. The ESC did a conference a couple of years ago. Our Canadian colleagues, Dr. Etter, does a conference every year as well. We do a virtual conference series. If anybody does not know, please email me if you'd like to join. Of course, the IMID partnership, as well as the partnership between the fellows. And so with that, I just want to thank everyone at my institution at the Brigham who really fueled all the work you saw today, my new institution, everyone on the call today, and my dear colleagues sitting in the audience, and the UK Cardio-IMID Partnership for the ability to be able to talk to you about this today. So thank you very much. And here's my email if you have any questions.
So virtual thanks, even though she can't hear us. Thanks to Brittany. I think it was a really perfect end to this day that captured all key aspects that we've been covering throughout the day, but actually she covered the whole spectrum of cardiovascular pathology, actually, in a sense that our patients are at risk of. I don't know if people want to ask any final questions or not, otherwise can close for the day. I think Brittany has really touched upon these areas. These are all the key elements and the gaps and challenges we find ourselves when trying to improve management for people with autoimmune diseases and trying to improve the cardiovascular outcomes. I'm not going to go through any of this again. I think it's just to draw a meeting to a close. We'd really like to, we're really grateful to all the speakers, the abstracts, the cases, their superb presentations and your contributions online and also in the audience. It's what's made it highly stimulating and interactive, and we're really grateful for that. We're really keen, as I said at the very start of the meeting, for you all to keep involved, stay involved, please do, and these are just look on our website again for updates that are happening in the cardio-rheumatology community. Just highlight that this today will be recorded. That will be available on our website. Also, the partnership's been developing a cardio-rheumatology curriculum, a webinar series that will be coming soon, and this will be in partnership with MedShare. Asif Kazim, the chief exec, is here today, and so this is really going to broaden out the scope and the reach really of the webinar series we have, and that will be going through iterations each year. So again, we'd really value your input as we do start developing this. We've mentioned the UK registry a few times. If your hospital is involved in this, brilliant, do get involved. If not and you're interested, do get in touch. James is your man. His contact details are there. He's a great first port of call and can get you navigate, etc. And Georgia actually is our study coordinator for the registry, so she's a specific contact for the study as well. For our early career researcher group, we have a ECR group. Many of you are here. Leho Gumba is oversees that ECR group, but many of you are getting more and more involved in that. Please do create your own young cardio-rheumatology network. It includes cardiologists and rheumatologists. Do discuss and exchange ideas, and it's a forum for you all to actually not do things necessarily separate to us, but certainly that's relevant in your space, and you can learn from one another and see what kind of research each other's doing. We had advertised these sabbaticals for younger researchers and clinicians. We've repurposed that into these taster week visits, and we'll be advertising that soon. So if you'd like to visit another cardio-rheumatology unit in the UK, that will be going out. Is that live soon? It's out already. Yeah, I'm behind already. So that's out. So please do, again, details on the website. Please do look that up. It's a great opportunity. They're 1 week tasters, but we will be hopefully extending that into the originally planned 3-month type sabbatical to make it a bit more substantial. And have I missed anything else, guys? Sven, Taryn, Jason? No. Just yes. So, like I said, the recording will be on the website. Yeah. And so this was our educational conference. We'll be doing this every year. We have our annual scientific meeting at Edinburgh, Friday, 13th March. Please do attend. Do spread the word. Your youngsters, I don't do social media, but please do spread the word and do your thing. It'd be really cool to get as many people involved.